Today, I'm going to be discussing CVR and how success begins with the right stimulus. So I'm going to begin with declaring my conflict of interest. I receive salary support from Thornhill Medical, which is the manufacturer of the Respiract, one of the gas delivery systems that I'll be discussing today. And it's a system that I use in my research. Cerebrovascular reactivity, or CVR, is defined as the change in cerebral blood flow for a given vasodilatory stimulus. It indicates the extent to which vessels are able to accommodate demand for an increase in blood flow. It's important to measure CVR because impaired CVR is associated with many pathological conditions such as stroke risk and carotid artery disease, traumatic brain injury, etc. CVR is able to identify pathological responses in cerebral vasculature, and it has the potential to be used as a diagnostic aid, such as determining the presence of hemodynamic impairment for management of treatment. So to measure CVR, you need a vasoactive stimulus and a measure of cerebral blood flow. Blood flow can be modulated locally via neuronal activation through something like finger tapping, and that's fine if you want to interrogate a specific region of the brain. But the brain is this neurovascular unit that's vasculature is all interconnected. Therefore, giving the same stimulus to every part of the brain or a global vasoactive stimulus allows for us to measure variations in blood flow distribution between different regions of the brain. The most commonly used global vasoactive stimuli for CVR are acetazolamide and CO2. There are a number of measures for cerebral blood flow, including SPECT, PET, MRI imaging methods, such as ASL and BOLD. And here are two images that show CVR measured using a combination of the methods I just mentioned. The top image shows SPECT and PET at rest and then after acetazolamide. And then the bottom image shows ASL MRI and BOLD MRI with CO2 given as the stimulus. Today, I'm going to focus on the stimulus. So let's begin by looking at the different types of stimuli used to measure CVR. As I mentioned in the previous slide, the two most commonly vasoactive stimuli used for CVR measurement are acetazolamide and CO2. Each have their own disadvantages and advantages, but I'm going to focus on CO2 and different methods of delivery. CO2 has been shown to be safe, easy, and an effective stimulus. That being said, the three methods listed in this slide are the most commonly used ways of administering CO2 for CVR measurements. So those are breath holding, fixed inspired CO2 methods, and computerized prospective targeting. So let's dive deeper into these CO2 methods. First is breath holding, which is simple. You just ask a subject to hold their breath, and the CO2 levels will slowly increase, and that will cause cerebral blood flow to increase. However, to get any sort of measurable or effective change in CO2 and therefore cerebral blood flow, if you see it on the graph on the left, which shows CO2 on the y-axis and time on the x-axis, to get any sort of measurable or effective change in CO2 and therefore blood flow, you need to at least hold your breath for 20 seconds. Also, the variability of the increase in CO2 over time from one person to the next, it can be large. And while your CO2 increases during breath hold, your oxygen level decreases as shown in the graph on the right. Also, the amount of CO2 that rises will depend on if you fully expire before you breath hold or whether you hold your breath at the end of inspiring. So there's lots of influencing factors with breath hold that you just have to keep in mind and take into account when you're determining your breath hold paradigm for your study. Breath hold is very attractive. It is inexpensive and it's easy to implement. It requires patient cooperation, which for the most part isn't an issue. But from my personal experience, for some reason, when you ask people to breathe on demand or to follow some sort of breathing maneuver, for example, it's like all of a sudden you're asking someone to hold their breath balance a ball on their head, and jump through hoops all at the same time. And I'm guilty of that as well as the subject. The CVR repeatability is okay, obtained using breath hold. I've seen normals that the variability in the repeatability can range from 20 to 30%. But I've also read over the recent years analysis methods which improve the reliability and validity of breath hold CVR. Another method of administering CO2 is fixed inspired, which consists of breathing between 2 to 7% CO2 via a tight-fitted, non-rebreathing face mask and measuring CO2 levels at the mouth. This method is often able to produce a standardized hypercapnic stimulus. This method delivers pretty nice changes in CO2, as shown in this graph on the left. It's fairly inexpensive. The parts for the circuit you can get off the shelf, and doesn't require the same subject cooperation as in breath holding, for example. Step changes in CO2 are possible with this method within somewhat of a reasonable time frame, but you can see from the graph here that there's a slow exponential rise in CO2, and even after 2 minutes, you still haven't hit a steady state. So also keep in mind what's delivered and being measured at the mouth isn't what's always occurring in the blood. So it can vary both between subjects and within the same subject over time, as you see from this plot here, which shows the CO2 values and tidal, and then at arterial are completely different. Also, CO2 triggers your drive to breathe, and everyone has different sensitivities to CO2. I know I'm sensitive to CO2, and when my levels increase, even just by 5 millimeters of mercury, I start breathing harder like I'm running a marathon. Increases in ventilation responding to the CO2 in the inspired gas will end up lowering the CO2 stimulus. And as a result, regardless of continuously inspiring increased or 5%, 7%, whatever you're giving, the CO2 caused ventilatory response may produce an unchanged or even lower CO2 as shown in this column right here. Last, you have computerized prospective targeting. Subjects are fitted with a face mask and connected to a sequential gas delivery breathing circuit, and desired patterns of targeted end-tidal CO2 and O2 are programmed into the automatic gas blender, which directs mixtures of oxygen, carbon dioxide, and nitrogen into a breathing circuit according to a prospective targeting algorithm. End-tidal gases are sampled at the mask. The system can give you repeatable stimulus, and it's been proven that what is measured at the mouth is what's equal in the blood. Lastly, on targeting, end-tidal CO2 and O2 are independent of changes in ventilation. So a person starts breathing harder due to the increase in CO2, and the system is able to compensate and keep them at the desired targets. So here on the slide, the first graph here shows subjects end-tidal CO2 in red and O2 in green being changed sinusoidally at the same time in sync, and then at this point, it goes out of sync. The middle graph shows CO2 and O2 sinusoidal changes at the same time, but at different frequencies. And the graph on the right shows fast step changes up and down of CO2 and O2, again at the same time to different state levels within like a breath or two. There's disadvantages to this method too, and that includes equipment setup. There has to be user knowledge on how to use this device, so the training's involved. And there's costs associated with acquiring and maintaining this device. Full disclosure, this is the method of delivering CO2 that we use in our lab. We have run CVR for over 20 years, both experimentally and clinically. Our technique for evaluating CVR consists of giving CO2 coupled with bold MRI to measure changes in blood flow. The picture on the right just shows our gas delivery system on a subject in the MR environment. And I just wanted to show you quickly an example of the CVR maps we create, as I will be showing a lot of these maps throughout the rest of the presentation. We obtain a structural scan, and CVR values are color-coded to a spectrum and overlaid onto their anatomical scans. The CVR color scale, which is found at the bottom of the slide, and corresponds to the direction and the magnitude of the correlation. So here on the left, you have the normal CVR. And then on the right, we have a CVR on a patient with left IC occlusion, and it shows the entire hemisphere having hemodynamic impairment. So I mentioned we've been studying CVR in our lab for 20 years. I just wanted to summarize our tolerability and experience with CO2 because we get this question a lot. We've done over 1,400 CVRs, and that breaks down to approximately over 200 normal scans and over 1,200 patient scans, approximately. And the patient scans mostly include large vessel disease, such as carotid artery stenosis and moya. The top graph shows the percent of patients out of 1,200 scans that underwent a CO2 stimulus, which was approximately 92%. And the remaining 8% of patients did a breath hold. For the 92% that had a CO2 CVR, the middle graph just breaks down the type of CO2 stimulus they underwent. But the last graph, which I find very interesting, shows the distribution of the reason why the 8% of patients underwent a breath hold instead of the CO2 stimulus. So 1.7% just flat out refused to participate in a CVR study at all. 3.5% underwent a breath hold as our gas delivery system was unavailable. And finally, one of the most interesting data points is 3.2% couldn't tolerate the CO2. That's pretty good. But the most important issue is that over 20 plus years of doing CVR and over 1,400 CVR cases in total, we have not had a single adverse event to CO2. Over the years, we've come across very interesting principles regarding the stimulus and its effects on CVR. Regardless of your method that you choose to use to deliver CO2, whatever way you choose to deliver the CO2 to measure CVR, one of the most important requirements in using CO2 is to ensure an understanding of how brain blood flow is redistributed in response to a vasoactive stimulus. Why is that? Well, this is what I initially saw with respect to cerebral blood flow response to CO2. This top subject is someone with bilateral moya, and I measured their CVR going from 40 to 45 and 40 to 50. And I happened to do this just, by fluke. And you can see that going from 40 to 50, they have much more hemodynamic impairment than going from 40 to 45. And I found that interesting. So another subject came in with a right IC occlusion, and their resting value, CO2 value, was around like 35-ish. So I decided to run a CVR going from 30 to 40 and then 40 to 50. And from 30 to 40, the patient's CVR is completely normal. And it's only going from 40 to 50 that you see hemodynamic impairment. Subject 3 had a baseline CO2 value around 30. So I did 30 to 40 and 40 to 50. And 30 to 40, the CVR looks great. It's very robust. 40 to 50, it looks washed out. And I took this to my supervisor, Joe, at the time. And I said, Joe, what do you think of this person's CVR? And he says, whoa, get that person to the neurologist, refer them right away. And I said, whoa, hold on. This is my CVR. What's going on? Here is a theoretical illustration of a brain vascular territory with a partially stenosed vessel branch and a healthy branch that's in parallel, supplied by a major feeding vessel with resistance. So at rest, in order to supply the metabolic requirements of the tissue served by the stenosed vessel, the diameter of the vessels distal to the stenosis end up increasing over here from its original diameter, and it encroaches on its vasodilatory reserve. When a general vasodilatory stimulus, such as an increase in arterial CO2 is present, it will stimulate all the vessels to dilate. So the normal vascular bed over here has room to dilate, but these vessels over here that are already dilated at rest will end up having a reduced range of response. So based on this theoretical model, we proposed this hypothetical response model for blood flow response to CO2. So red is the sigmoidal response of normal vessels in isolation, and the dashed blue line depicts a reduced amplitude of the response of the partially stenosed vessel branch when coupled in parallel with a normal vessel branch showing steal in the hypercapnia and reverse steal in the hypocapnia. CVR in the vascular territory with adequate vasodilatory reserve will be greater for increases in CO2 going from 40 to 45 versus increases going from 40 to 50. In contrast, a vascular territory with a significant stenosis may end up having a positive CVR, such as here, where the CO2 change is in a range where there's some vasodilatory reserve that's preserved. But with a greater stimulus range going from 40 to 50, these vessels reach their vasodilatory limitation, and a continued vasodilatory capacity in other regions will end up inducing steal. So this determined if this is correct, we examined the hypothesized model experimentally using progressive changes in CO2, as shown by the red curve, in order to get a full measure of the bold change over the entire range of CO2. So this is a patient with a right side moya-moya and a resting CO2 of 35. When we go from 40 to 30, we see that flow changes in response to decreases in CO2 in the affected hemisphere. Increases from CO2 from 30 to 40 create CVR maps that show the hemispheres may be impaired, but cortically the reactivity is okay. It's only when we go to the real hypercapnic range from 40 to 50 that we see the true amount of hemodynamic impairment in that right hemisphere. And finally, decreases in CO2 going from 50 to 40 show the blood redistributing into the hemispheres that were being stolen from. Recall our hypothetical model that you can see in the top left-hand corner, and we can confirm these hypothetical predictions. When we look at specific ROIs in the same subject, we find in a voxel with normal CVR, we have nice sigmoidal curve as represented by the red line. In an area of low CVR, we have a dampened response, as you see with the yellow curve, and a voxel in an area with hemodynamic impairment, we have the signal initially increasing to a threshold around 40-ish. If we look at, this little curve here, which is the same curve, just expanded y-axis. So a threshold about 40, and then after that, it begins to decrease as the CO2 continues to increase. So in summary, an important principle derived from this model and data was that the absolute magnitude of the stimulus has to be adequate to maximize the ability to identify areas of reduced vascular reactivity. So it emphasizes the importance of having a precision in the administration and measurement of the vasoactive stimulus. You have to make sure you know how much CO2 you're giving and that you're giving enough. Understanding the choice of stimulus and pathophysiology of cerebral blood flow to CO2 can aid in the exploration of the development of standardized methods of CVR for clinical utility. And that's what we've been trying to do in our lab over the years. For example, we investigated development of a standardized method to aid in a quantitative interpretation of CVR maps. How can a clinician quantify abnormality? So the current assessment of CVR maps consists of a qualitative review of abnormalities, which requires experience on the clinician's part. So we suggested a less subjective criteria is needed and proposed a quantitative method where individual CVR maps are compared to a normal cohort. So what we do is we create CVR normative atlases. CVR studies of a cohort of healthy subjects, all undergoing the same CVR protocol, including the CO2 stimulus, are co-registered into a standard space, and a voxel by voxel mean and standard deviation CVR is calculated to form a CVR atlas. And then patients that have undergone the same CVR protocol can be scored against, scored by assigning a Z value according to the mean and standard deviation of the corresponding voxel of the atlas. Very simple, Z scoring. The Z values we color code to the color scale shown on the slide, and we superimpose them on their anatomical scans to form Z maps. Here are three examples. A is a healthy normal, B is a patient with left ICA occlusion, and C is a bilateral moya-moya disease with normal appearing CVR. Displayed is their CVR maps and corresponding Z maps. Z maps indicate the distribution and quantify the deviation from normal. It also gives us more information than just CVR maps alone. For example, look at subject C. Although some areas have positive CVR values, they're actually highly abnormal compared to the normal distribution if you look at the Z map. So by controlling for regional CVR differences among subjects, Z maps highlight reductions in CVR not apparent in conventional CVR maps. So Z-maps allows us to examine changes in a patient at a single time point, but CVRs are also useful for monitoring the progression of a neurological disease over time and looking at differences pre and post intervention. Therefore, we need a method of assessing repeatability. So to examine variability among time points, we create something called interval test difference, or IDZ-maps. We love our acronyms in our lab. We measure CVR scans at 2 separate time points in healthy controls. Both scans for each individuals are co-registered in standard space, and a normal difference CVR map is calculated from the 2 time points for all voxels for each of the subjects. And from those differences, you calculate the standard deviation across all subjects for each voxel to generate an ID atlas. And then patients that undergo 2 or more CVR studies with the same protocol can be scored against the ID atlas, similar to the Z-map approach. And the Z values are then color-coded and superimposed on their anatomical scans to form what we call ID Z-maps. So here's an example with a patient with bilateral stenosis who underwent 5 CVR scans. You have pre-bypass and then 5 months post-bypass, and it looks like the CVR got better. The ID Z-map confirms that that affected hemisphere that was operated on did. Follow-up CVR shows that the CVR looks like it actually got worse, and you can see that the Z-map does show that that affected hemisphere did get worse. And then another follow-up month, 18 months post-bypass, looks like maybe it improved since the last CVR, and it did a bit. And then 35 months post-bypass, the last CVR follow-up, you can see that maybe it got worse, maybe not. And it shows that it kind of did. So it's doing this whole like improvement post-bypass and then follow-up, you know, it gets worse, gets better, gets worse. What our neuroradiologist always wants to know is that the current CVR, did that improve from the pre-bypass, the original first CVR? And yes, it did. So the application of ID Z-maps enables a quantitative study of the natural history of cerebrovascular disease in response to treatment. A quantitative and reproducible stimulus can allow for very interesting analysis that further examine the physiology and also perhaps helps us better understand pathophysiology in conditions that don't have these large areas of CVR impairment like we see in large vessel disease. So an example is shown in this slide here, which looks at dynamic changes in CVR, which is possible if you have these rapid increases in your stimulus from one steady state to another. So in A, we have the CO2, the end-tidal CO2. We can evolve the end-tidal CO2 with a set of first order exponential functions whose time constant, which we call tau, is increased in 2-second intervals. And then the time constant corresponding to the best fit between the signal and the convolved end-tidal CO2 is used to score the speed of response. Below, we have maps of examples of the time constant of response in healthy controls, which average values range anywhere from 20 to 25%. We have mild cognitive impairment, which looks like, you know, the response is a little bit slower. And then we have Alzheimer's, which shows even longer response times. Further information regarding the speed of response can be found in Poblanco, this publication right here, as well as the next speaker, Alex, will be getting into this in a lot more depth. Further analysis have shown that with slow, steady ramp-like increases in CO2, the bold signal response profile can also be further analyzed and put through a model to assess underlying vascular resistance changes. And parameters that make up the voxel-wise resistance curve can be mapped and further examined, as shown here. So here are displayed all the resistance sigmoidal curve measurements. So we have amplitude, midpoint, range, resting sensitivity, resting reserve, and the quality, which is just the coefficient of determination of the examined voxel resistance sigmoid. For sake of time, and because I could never explain resistance modeling in a way that would do it justice, for more information regarding this methodology, I refer you to this publication here, written by the creator of the resistance modeling, Dr. James Duffin, and also just email me and I can get you in contact with Dr. Duffin, who always welcomes people using his model and discussing more about resistance with them. I wanted to quickly end my presentation, just 2 more minutes, explain the clinical implications and importance of CVR for clinical utility. Current assessments for medical management of patients with carotid artery stenosis looks at the percent stenosis and how much collaterals are present in these anatomical tests, which is inadequate because you can't see the small collateral vascular system and it doesn't determine the functionality of these vessels. They just tell you if they're present or not, not if they can provide enough blood flow to compensate for the percent stenosis. Oh, but CVR can determine the adequacy of collateral blood flow in the entire brain, such that if the collaterals are present, and can it provide enough recruitable blood flow on demand in the presence of a stenosis? So presented in this graph is the relationship between degree in stenosis and CVR as a Z-score. And you can see from the greater the stenosis, the lower the Z-score. There's also variability in the effect of percent stenosis on CVR at the higher percent stenosis categories, suggesting that the variability across subjects increases with greater stenosis, which may suggest the greater the degree of stenosis, the greater difference it makes if there's collateral blood flow. Such as this patient here. This is a patient with 100% bilateral IC occlusion and has both a normal CVR and a ZMAP, and that's because they've developed sufficient collateral blood flow. And here's an example of a patient in our database with left 70% and right 40% stenosis. And you can see that the CVR shows impairment on the left, but the right side's not too bad. But the ZMAP shows both left and right hemispheres are greater than 2 standard deviations from normal. So in summary, from everything I've discussed today, steal physiology is highly dependent on the absolute magnitude of the vasoactive stimulus. Assembling standardized CVR tests can generate both a between subject normal cohort atlas and a within subject longitudinal atlas, allowing for quantitative, clinically useful CVR imaging assessments. A standardized quantifiable stimulus can allow for further important physiological measures to be explored, such as response time and resistance. And finally, a CVR stress test detects hemodynamic impairment in patients with carotid stenosis, independent of the degree of stenosis, and it's able to give us more information than just degree of stenosis alone, or what's going on at rest, which is if collateral blood flow is adequate or not. And this is one of the main clinical advantages and attractiveness of CVR. Thank you very much.